Good afternoon, and welcome to Keys to Improving Patient Flow for Better Clinical and Financial Results, a complimentary webinar from HealthSystemCIO.com, sponsored by MedHost. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I'll be your moderator today. We encourage you to ask questions. It's a featured part of our program. Go ahead, type them in as they occur to you in the lower right-hand corner of your screen in the Q&A box. We'll leave the default set to all panelists, and we'll pose them later in the program. And you will be able to download the deck. The URL's in front of you. I'll send it out in the chat box, and there's a shortened URL at the bottom of all your slides. And we are recording today's event, so we will have an archive available. Usually within 2 business days, if not sooner, you'll get an email when it's ready, and a separate registration is required. Just so you see how we're going to spend our time today, we're going to first hear from our friend Ed Ricks, VP and CIO at Beaufort Memorial Hospital. Then we'll hear from our sponsor, represented by Tom Mitchell, VP of Marketing with MedHost. Then we'll get to our Q&A with Ed. So without further delay, I'm going to turn it over to Ed Ricks. Ed, thanks again for joining us.
Okay, thanks, Anthony. I appreciate it. And thanks for joining, everybody. And as Anthony said, my name's Ed Ricks, and I work at Beaufort Memorial Hospital in Beaufort, South Carolina. And so just to, I guess, give you context on our size and what we do here at the hospital so you can see how that fits in with you, we're one of the I guess one of the lifeblood of healthcare, right? So we're a not-for-profit, private, independent community hospital in South Carolina on the coast on Intracoastal Waterway, which is a beautiful place to be if you've never been there. In fact, maybe you can see in the picture, although it's kind of small in the background behind that. So that's a hospital right on the water. Behind the other end of that picture there's a bridge, and that's actually the bridge that Tom Hanks ran over in the movie Forrest Gump. So even though in the movie it says the Mississippi River, they actually filmed that here. And so it's a really cool area, a lot of nice things going on. Busy community, you know, we're licensed it for 197 beds. We do about 10,000 annual inpatient discharges a year. Our emergency department volume is through the roof anymore. We're over 60,000 visits and tracking for probably closer to 65,000 this current year that we're in, which is pretty busy for us. Well in excess of 300,000 outpatient visits, about 1,650 employees now I think we have, and 200 physicians on our medical staff. So that's who we are. I guess the one thing that's really important is to understand, like many hospitals, we are really, really busy here, and our volume, it just never seems to slow down. And so historically, it's been a busy community. It just seems to be growing and growing and growing. And so we've had a few challenges around patient flow, and that was one of the initiatives that we took after probably 18 months ago. We started some hospital-wide initiatives to see how can we better get patients through the hospital, get them out of the ER when they're to be admitted, you know, get them home when they should go home, try to reduce costs. I mean, all the things that everybody talks about is, I think that one of the things we all really work on with the declining reimbursement and some of the other challenges is how can we become more efficient as a healthcare organization, and obviously that's just one of the key things to keep moving forward. So we looked at all these things that we wanted to try to work on and improve in our area. The problem is, and this is one thing, and you know, I know it's funny to hear the CIO talk about this, it's just the way things have worked out here. I've been really involved in the processes that we're trying to do, but patient flow obviously is very, very complex. You've got all the different things going around the organization from the patient flow perspective, the admitting tendencies of physicians in the ER. You've got, you know, the wrong people coming in the ER. It's so crowded in there. The issues with, are they inpatients, are they outpatient observation patients? How do we work with the patients and some of the culture of the family members to actually get the patients through quicker? The other services that go around getting rooms ready sooner. You know, I guess it's always a good problem to be so busy. I know the converse is probably not a good problem, but there's a happy middle ground is to at least know that we're being as efficient with what we've got as we can. Obviously, the benefits, I think everyone understands this, you know, one of the things we're always striving to do is to reduce our length of stay. That's good for the patient from a patient satisfaction perspective. It's obviously good from a cost containment perspective. We need to create capacity that doesn't exist because the rooms aren't going to multiply. We're a CON state. You know, it's really difficult to actually get licensed for more beds. And honestly, I don't know that that's what our real challenge is. I think our challenge is just appropriately using what we have. You know, we all have to be aware of Joint Commission and be compliant with regulations, but they certainly have a number of things that revolve around patient flow and their expectations. And in fact, we're due for our triennial visit here in any time in the next probably 3 or 4 weeks at the most, I would think. So it'll be good that we can talk about some of the things we've done when they get here. And clearly you want the patient in the right level of care. You don't want them tying up a more expensive resource for a lower reimbursed patient just because that was the only bed you had available and those kinds of things. Always now keeping your eye on readmission reductions, and because those things start to impact our reimbursement and any operational efficiency that you can do. And those are all the things that we want to keep in mind. And, you know, so you think about just making this change, just do everything better, it'll work, and it's not as easy as you think, you know. And our challenge is we don't have unlimited staff, and we don't have, you know, the expendable labor and just an unending amount of time to do all of this work. We also, everybody has their jobs. The nursing staff has their job, you know. It's not getting any less for them. So all the patients, it seems like they're more acutely sick than ever before. You know, our staffing ratios don't change. We've got many other competing priorities in the organization to work on, and fixing this problem is not simple. And trust me, I'll tell you now, and I'll tell you again later on, we sure haven't done everything right, but we have learned some lessons, I think, along the way, which is nice. And here's sort of the competing priorities that I was talking about. You know, there's just so many things going on that have to happen, have always had to happen. Maybe we're changing the way we do some of the things. Some of it I think you can blame us and IT for, but I think it probably, hopefully for the right reasons, because we're trying to improve quality and patient safety. But, you know, just throwing in CPOE changes the whole dynamic of a patient visit and some of the things that go around that. But so many other factors that everybody's all tied up in from top to bottom in any healthcare organization. So when we started, and I guess we actually probably started this whole project 2 years ago now, you know, we decided, well, here's one thing that organizationally we've done historically a pretty good job with is we'll try to implement a technology solution to help with this. And one of the things I've said here before is, you know, sometimes just implementing a computerized system is just a good way to screw things up quicker, you know, if you don't really think about what you're doing on the back end. But we did implement some technology to track patient flow, and it's actually a very cool product. Put it in place. It reads from all of our disparate systems. So we have a different main EHR in the acute side than we do in our emergency department. And we've got some integration between the two, but it was nice to sort of have an overlay that would look at data from both, real time, manage what's happening in those areas. You could see the kind of the look ahead of what's going on. But really what ended up happening was we did not do a very good job of implementing this software, and I don't mean that from a technical perspective, and I think we feel like we did a good job then, and even probably from an initial training, I think we did a nice job with the nursing staff, with the ancillary staff that had to interact with this. This just happened to be something that touched almost everyone in the organization, different than many of the other implementations that we've gone through, and I think what we didn't do was really think about the processes and how we were going to have to sort of address that. And so this is sort of my slide that says, you know, you can't just throw new technology on old processes because it's not going to make an improvement that you're hoping for, even though we thought we were doing all the right things. And so we learned a lot of lessons from that. And what it made us kind of do is step back and think about, okay, what are we trying to achieve here? I mean, there is definitely a technology piece that's going to be necessary just so that everyone can communicate more effectively and see the information of what's going on from a flow perspective. More importantly, and this is the part that we didn't address very well, is the whole workflow process redesign. And it was really funny because I think we do that well usually from an IT perspective here when we're implementing new software. We went through an EHR integration about 4 years ago and really try to pick things apart and take advantage of utilizing the software and change our processes. But it's really funny, when we did this, we didn't think about it that way. We just thought about, let's get all the data out there. That's what's missing, is that visibility of what's going on, and then people will adapt as they go. And we just did not handle it real well. So you've got that whole process redesign. Truly, this is just one giant performance improvement initiative. And probably the most difficult part, and that's what I'll speak to in a little bit, is sort of the cultural part. You know, how do you hold people accountable, something that historically we haven't done well, and I think most hospitals struggle with that. We all talk about it. It might even be one of our values. I never remember some of those things, but, you know, truly holding people accountable to do the right thing consistently every time to make these improvements that we look at. is hard to do. It's really a difficult thing to do. But somewhere in the middle, when you take those two things and kind of overlap them, that's when you really start to get this optimization of patient flow and efficiency, and it's using the technology and changing the culture and thinking about process redesign through all of that. That's the hard part. We didn't have that to begin with. You know, the good news was we partnered with somebody who said, all right, listen, you've got great software. Here's the parts missing. You've got to understand that. And we did. We certainly owned that from an organization perspective, but we needed someone to sort of help lead us through making these changes be a little bit more effective, be sustainable, and happen quickly. You know, we didn't want to drag this out for 3 or 4 years to see how things would mature over time. It's let's drive this home fast and do it. So we looked at the processes that we have, you know, and tried to make this targeted approach to really improve care delivery. Clearly, that's what we're all trying to do. You know, we want quality outcomes. We want this to be a good experience for the patient. That's really the goal of everyone in the organization. I think in every organization that you guys are working with, you know, that's all that we're trying to do. There's a lot of things that have to happen to make that work, but that's really the ultimate outcome that we're looking at. We sort of broke this down into 2 or 3 items that said these are the most critical things to look at first. As we do this process, and this will not be anything unusual to you. You know, one is certainly the discharge processes. How can we make that more efficient? How can we plan discharges more effectively than we've been doing today? Through some of the data that we brought forward with the system that we had, it was really clear, and all this did was validate something that everyone in this organization, particularly in the senior team, knew in advance, is that our care management team, they were busy being busy. You know, they worked super hard, but we were very ineffective. And I think that model needed some change, and we needed some leadership to get through that. So that whole discharge process was a big component of what we wanted to do. And then obviously, because this patient flow is the bed management, is how do we get the beds turned over? How do we know where patients belong? How do we know which units have which mix of patient-nurse ratio in real time, all the time? How do we know what's going on with the patients in all of those rooms just at a glance without having to dig into our EMR for all that information? And then thinking about the flow of the patients and what do we do with that? Clearly, that's just me summarizing, you know, patient flow in 2 slides, but those were the 2 big things we want to dive into to think about this as a project, because our plan was, let's take the technology that we have, create visibility into the organization, and let that drive the accountability to people. So then it's easy to tell what's going on in each area and even who is responsible for what. And I think that as I talk about some of the metrics that we measured and looked at, you'll understand what that means to us. So this is what we said. All right, we're going to start this project. We did get some good leadership and consulting services to sort of help us build a structure that we needed to make this sustainable. We had to have executive level sponsor buy-in and really drive it from the top down. This wasn't going to be driven just from an IT perspective, just from a nursing perspective. You know, it was going to be bigger than that. This was an organization-wide commitment, and one of the first times that we've done something so big that had such an impact on so many different people. And like any other project, if you're going to do it well, you got to measure some things that are meaningful and continue to measure and look for improvement on that. And so what we first came up with was a structure for sustainability is probably what I would call it. And in that, you know, the key thing that was missing from us before was what became this process action team. And if you see on the chart there, so at the top, we've got an executive level committee. So all of us from the senior team are on that, led by our CEO. Then below that is a steering committee, which was myself, our CNO, our VP for quality risk, and then a few other people like our PI person and a few other folks who are very good at strategy and thinking things through and trying to drive this process. But really what made this work was that little bottom box in the middle of this process action team was made up of about 30 or 32 people, I think, and not just managers and directors. You know, we wanted this to be truly driven by the people who do the job, which is brilliant. In fact, we've just gone through our first phases of lean training here as an executive team in our organization. We're starting a new project that's going to kind of replace the way we do performance improvement going forward. I wish we'd have had some of these fundamentals in place when we went through this a couple of years ago. I think it would have helped us understand better, use some different tools to be a little bit more organized and work through things. But regardless, we didn't, and we sort of learned it this hard way. But that process action team was critical. So this was 30-some people who actually do the jobs in all the areas, environmental services. We had physicians, we had discharge planners, we had emergency department folks, we had inpatient nursing folks. You know, this IT was involved, education was involved, all the people who can help make these changes in the organization. And it was great. So these folks looked at data because we had good data now. We had something that was believable and people understood it and trusted that data. We could start to make some data-driven decisions and pick apart a process and just look for something to change that may make an improvement, create that change, get it out there, measure it, see if it worked, hold people accountable. And that's sort of where we still started hitting stumbling blocks, you know, and that's my culture part of this, I guess. And it was funny, this first couple of weeks of this initiative, we actually touched almost everyone in the organization to some kind of education, training, communication across the organization. And it was kind of, this may give you some insight on what kind of person I am, but it's kind of fun from my perspective to see everybody be really uncomfortable for the first time in the 5 or 6 years that I've been here. And that was good because people were starting to think about how they do things, how can we improve. And we were putting people in positions that they'd never been in before, folks to speak up and say, no, here's how this process will work better. Trust me, I do it every day, versus a director saying, here's the best way to do something, you know, and the data was supporting those changes. But culture is really, really hard to change in any organization. Ours, I'm sure, is no different than most. And so this hospital has been around for 75 or 80 years. The culture is that old. Some of the ways we think, just from a personal perspective, go back that far, and it's really easy to get caught up, and it's really hard to change it. But we were going to. So this is where we said, all right, we're going to do these things. This group is working really hard. We're going to educate it back out, and we're going to hold people accountable. And then this happened, right? Said, okay, we're going to get a lot of resistance, and we did immediately. You know, people, I'm going to quit my job. You can't change my hours from what it's been for the last 5 years to this just because you think it's going to help improve patient flow, you know, and all those things. And so it was really up to us as a senior team to challenge that resistance, the hardest thing to do. Really stand up every single time, say, no, we're not going to go back. This is what we're going to do. It's for the right reasons. Here's the data that supports that, and move forward. Hardest thing to do, though, is to continually challenge that resistance. But that's the only way, I think, to get something that's kind of sustainable from a long-term performance improvement, at least in this organization. That's made a difference. So some of the things we did to sort of make this work was the communication campaign that I talked about started from our CEO sending out information via email, via our newsletter, you know, on what we were doing. We actually had a contest to name the project, and we ended up going with Catch the Wave, and it was Catch the Wave of Patient Flow, but also sort of took advantage of our coastal theme and surfboard, and so we had a surfer dude that got named by through a contest, you know, that people put in for, and that kind of thing, which made it kind of fun. It made awareness a big deal, and so everyone understood what their role was and why we were working on this. Certainly just the focused efforts on the processes to do these things, recreate some positions and responsibilities that made more sense. Looking at discharge planning, that was a big piece of what we were doing. Revising workflows, this continually goes on. Again, we're still not perfect at it, trust me. We're working hard, but it's a lot of work to keep doing that kind of stuff. And then implement a good training program to educate staff on what it means based upon their role, you know, in the organization for patient flow and where they're going to touch it and how they can help with the improvements. And, you know, we actually had one nurse, I think, said something about, oh, this training we're doing on this is fantastic. Finally, I wish we'd have had this for some of our other IT implementations, and which, you know, I wasn't happy to hear that because we were always thinking that we're doing a good job. So I guess it's good to get that feedback, but then we truly felt kind of validated that we'd attacked it the right way this time through. So I mentioned our kind of focus on care coordination through this process, which I don't think I mentioned. We were trying to do this in about a 6 or 8 week period, which is get this infrastructure in place, get the training in place, start this process change, measure some things, make some changes, hold people accountable, and try to create that sustainability effort in a really short time frame. And that was maybe part of what made it so painful, but I think that was also part of what made it work for us to some degree too. And on care coordination, you know, we had to sort of change the way we thought about things. We historically always worked on discharge planning when the patient was getting ready to get discharged to some degree, and I don't, want to throw a blanket over that because we certainly weren't that poor at it, but we had to change the way we thought about it, that really discharge planning should start when that patient is admitted, or even before they're admitted. When they're in the emergency department, they're going to be, we know they're going to become admitted. The ER doctor recommends that. They talk with the hospitalist or the attending physician. There's a decision to admit. That's the time you start discharge planning right then. You've got an admitting diagnosis or something to work with. You sort of know what the length of stay is based upon that. That coding may change over time, but getting something for a working DRG right then or very shortly after that, so you can start to work backwards from a discharge planning perspective, it was just a whole shift in the way we thought, and that was something that ended up being very effective for us, and it has made a little bit of a difference on all these other things as we move forward. Change in the way the care coordinators, around with the physicians and the nursing staff, and just more communication and more visibility into what's going on in the organization, and those things combined have helped sort of drive that change. Obviously, we want to continue to utilize the technology, right? I mean, we've implemented this. We've got good data going to it. It comes from different systems. Everything pulls into one, very visual, and I know there are different applications that may do something similar. This worked really, really well for us because it could take the data from the different systems, makes it very visual. At a glance, you can see what's going on in your unit. If you've got isolation patients, if you've got patients that are fall risk or whatever kind of a risk that you want to identify, just at a quick glance, you can certainly drill down and get much, much more information. But at a glance from any unit, we put in the big jumbotrons, in each unit, and certainly everyone in the executive suites looks at this all day long. It's just one of the things that we keep running on our desktop for the most part, so we can see what's our overall census in a unit. We can see things that are showing up to us that are kind of outliers as far as maybe patients who have exceeded their length of stay or will be exceeding their length of stay in the next 24 hours. Look at all of the isolation patients at any one time, just any way you want to kind of slice and dice, but very visual, very quick. From the emergency department, you can tell what's going on from how many patients are we holding and things like that. So continue to use that technology and just kind of embed that into the workflow of how people do things. And certainly measure and then hold people accountable for that change. And we didn't want to pick too many things to measure because that gets in the way of trying to keep it simple enough to just effectively make small changes that add into big changes. So we were trying to look for 2 or 3 key performance indicators, for each area, essentially. We wanted realistic goals. You can adjust those over time, and in fact we have, and I'll show you some data in just a moment. This shows that we were effective in changing some of the things we were trying to do, and so let's change the goal. Let's get a little bit tougher, smarter with it, and work on adjusting those targets. But the key thing is to measure it and report it out to the people who are making the changes so that they can tell, that yes, their effort has been valuable, or we're spinning our wheels, we're still not making progress on this one particular item. Maybe we need to readdress it. Maybe sometimes you just step back and say, okay, we can't make that more efficient for whatever reason that might be, and let's just kind of move on to the next thing that may help. So just a couple of the sample KPIs that we did, and we kind of broke them into these categories of the care management team, environmental services, our house supervisor group, which those are the folks who sort of do the bed assignments for us. Everyone handles that a little bit differently. Obviously, the emergency department, statistics, nursing overall from the acute side, and then looking at discharge orders and how long to transfer patients between different levels of care. Those are the things we started out early on measuring. We've got probably, there may be 80 different elements we're measuring and looking at, certainly a few members of the senior team who are really involved, but each area there's just 3 or 4 things that are kind of important to them. One of the things that we clearly picked up right away from the data, you probably can pick it up just from anecdotal information and seeing what's going on, is if we have more discharges by noon, obviously that'll get patients out sooner. We can get them from the emergency department into the beds. Luckily, this 6 or 8 week period I was talking about, for whatever reason, we weren't as packed as normal, so it was kind of good that we could work through some of these things when there wasn't also the pressure of too many patients. I'll tell you, and I've heard this from a lot of my friends out there, that I don't think we're unique, but these last 3 months, we have been completely above capacity every day, essentially. even through the holiday season, which is really unusual. Part of it has been the flu season has been really big down here, but even before that, it's just a different dynamic in our community. Our emergency department is just so much more busier than it used to be. That volume of patients, is going to trickle down to inpatient admissions and things like that. So anyhow, we looked at discharges by noon and what can we do, and some of the things were really simple. We have a hospitalist group that probably sees 75%, I would say, of all of our inpatient admissions, and, working with them to just change their processes a little bit. Their kind of normal thing is when the morning group, when they came in, they would start to look at their most acutely sick patients first when they started rounding, which sort of makes sense if you think about it, but, they're already on a course of treatment. If you shift that around by an hour or two, it's probably not going to impact their treatment overall. If you can instead go focus on the patients that are to be discharged that day, get your final lab test done or whatever it might be that's going to hold up that admission earlier in that rounding and be done with those folks, that will give us opportunity to move those beds over quickly. And none of these things are rocket science, and probably a lot of you guys have figured them out, but actually just showing people the data to support the changes and following through with it, that's the key thing. Click ahead here. So we had this goal of discharges by noon, and we had a certain percentage threshold. And you can see when we started this, and again, this was August of a year ago, so it was about 18 months ago from now. We were about 10% discharges by noon. Within that 6-week period, we got that up to 45% and continued to go up and well over 50. In fact, so we ended up changing the metric to say, all right, now let's measure discharge orders by 10 a.m. and try to get that to move the number up and see what we can do there. And those couple hours, it doesn't sound like much, but that's what really helps in reducing length of stay. Some of the other things that we do, we certainly focused on the bed turnover time from the point the discharge order was put in and from the time the patient left, the room cleaning. And again, this technology we implemented helped us with those things from a technological perspective. It gives proactive pages to the environmental services people as soon as the discharge hits the system and things like that. So at a glance, you can tell if a room is dirty, occupied, if it's been cleaned. All those things are captured through a phone system of the environmental services uses so that we are measuring, again, those turnover times and we can hold people accountable. This group, maybe of all the other groups, I'll be honest with you, probably took the most pride in what they were doing, our environmental services, adapted to the technology fantastically and made some improvements and really ended up having a lot of pride in what they did afterwards. So it was really good, just turning down that bed cleaning turnover time. Again, a combination of process change and using technology appropriately and having the appropriate technology probably to help drive those things down. If you drop that, you can see from that graph over that 6 or 8 week period, we had about a 60-minute improvement in just that bed turnover time from the time the patient left to the time we could put a new patient in there. That's an hour a day. That's 1/24th of a day. When you're looking at length of stay changes, that adds up. So here's a length of stay graph over that period of time. Maybe more complicated than it needs to be, but the top is the observation hours length of stay. The bottom line is actually the inpatient discharges length of stay. And you can see that we had a little bit of a steady decline from 4 to 4.5 days. And I think our average was just over 4.5 before we started. And we got down, I think that 1 week was a little bit of an anomaly, but the data is correct. But our sustainable length of stay dropped by well over a half a day over that period. And we've stayed there or improved a little bit since then, which is great. The nice thing about that is this is maybe a little bit more of the sustainability you see from the 4.35, and that was after some of the changes were in place, to below 4.1. We've actually dipped down to like 3.9 to 4.0. And our case mix index has not changed. In fact, it's gone up just a little bit. We added a couple of service lines that have a little more complexity. So it's not because the patients are less acutely sick or anything. It's really kind of related to these process improvements that we put into place. What's nice with that length of stay reduction is there is a calculatable, very accurate cost associated with that time that a patient is in the bed that we've removed from the system. To me, it's harder to measure, and I'll show you a calculation we came up with for revenue that we gain because now we've got the potential of these beds back again. But for us, a half a day length of stay reduction based on our true cost from our cost report is well over $400,000 a year. May not sound like much, but that's pure cost eliminated from the system. You know, there was no offsetting revenue one way or the other for this. It's truly reducing costs, and that's a great thing. That goes right to the bottom line. Certainly, we're all looking to do as much of that as we can. So for us, this is kind of the summation, that 6 or 8 weeks, you know, we did reduce our overall length of stay, 4.75, that's what our beginning was, to 4.18 over that period of time. Case mix index, you see, did not really change much. It went up just a little bit. And in the subsequent year since that's been, it's actually, our length of stay has gone down a little bit more, and our CMI stayed about the same. I think we're 1.44, something like that this last month, if I remember correctly. So certainly that sustainability is important. Continuous improvement is important. Discharge orders written by noon over that 6-week period went from 11% to 43%. And as I mentioned, we adjusted the goals, you know, once we got over 50%. So let's measure how many are discharged by 10 a.m. Try to put more pressure on where it makes sense. You know, some things you can only go so far, but that can make a difference, and is purely just a different way of thinking about things. You know, it wasn't providing better or worse care for anyone. It was just doing it a little bit differently. Reducing time in the bed turnover, I mentioned. I think we're actually well below 62 minutes now, but again, there's some point that you can only go so far, and the folks are being as efficient as possible and still doing, obviously, the quality job that we expect from them. The best part was this, that's a typo, it's not cost continuum, it's cross continuum group of folks that, although cost is a big piece of it, but that process action team that I talked about, some of the members change over time. We continue to have these folks meet. We haven't given up on this, so even though it's long since gone that the consultants were here to help us form and sort of get this process going, we've kept it up, and I think that's important. Again, we still fall back in some of our old habits. It's really easy to do as an organization. Everyone's super busy, don't want to add extra work unless it's a value-added work, and we certainly feel like this is. I'm excited because now we're going to start to apply some of the lean principles across this group and move forward. And then easy financial costs that are calculable. Our CFO validated this, you know, both the reducing that cost of the length of stay reduction, and then what that means, because now you've actually got these rooms that you can backfill patients in, and we've got a list of patients waiting to go in every room every day, so that's good. I think we'd have been really stuck if we hadn't put all these processes in place before this volume hit us. I'm glad we sort of had that figured out. We're still learning. Trust me, we're not perfect, but at least now we've got, you know, both a tool that can help us be effective, a governance model that can help us be effective, and then the process changes going in, and kind of those things have pulled together. And Anthony, I think that's the end of the story.
Well, it's an excellent story, Ed. I want to thank you very much for sharing it. I look forward to a little bit of Q&A in a few minutes. With that, I want to turn it over to Tom Mitchell, who's with MedHost, who's supporting and sponsoring today's event. So, Tom?
Yeah, thank you, Anthony, and thank you, Ed, for such a great presentation and overview of your solutions. A little bit about MedHost. We're headquartered in Franklin, Tennessee. We have been in business in 30 years, for 30 years, and we really support quite a range of customers with over 1,000 facilities using our solutions, from our enterprise solutions to our departmental solutions and our services around the country, and really represent, you know, that 20% of the healthcare market. We're very well embedded into the acute care space. Have a significant presence in both the behavioral market as well as long-term market, and we have some solutions designed specifically for the specialty surgical market as well. Mentioned our customer base. We're in 46 states, Bermuda, Canada, and Puerto Rico. The diversity of our base, again, really is represented in the type of facilities we operate in and serve, and we range, from large IDNs, multi-tenant type facilities, to standalone large academics with some of our departmental solutions. So the 30-year legacy of MedHost really goes back to its enterprise solutions, where we have about 700 plus facilities using those solutions. We got our start really in the financial area in the early 80s with general financials and revenue cycle solutions. And now we have a complete end-to-end inpatient EHR serving both the revenue cycle and administrative side down to the clinical side. So our solutions are known across the board. Really specialize with our enterprise solutions in the 200-bed less market. But our departmental solutions, where we're known very well for our emergency department information system and our patient throughput solution, as well as our perioperative solutions. But those solutions will fit into any size hospital, and those are seen from critical access hospitals up to large academic type facilities, from rural settings to urban settings. Our services really focus on consulting. We have a large hosted and IT managed services offering as well, where we will host our solutions and then provide FTEs as well as remote employees to manage IT operations and data centers. And then we have a range of outsourced services designed specifically for our customers, such as patient statement and processing. Something new we're introducing soon. This is not out yet, but we'll be introducing this in the next couple weeks to give you guys a quick view of it, is Your Care Universe, which is our population health and healthcare engagement solution. So a platform to drive patient engagement, brand loyalty in your markets, true population health backed by detailed analytics specifically designed for a specific hospital. So look for more information on that in the coming weeks. And with that, Anthony, I believe wrap that up and turn it back over to you for Q&A.
Very good. Well, thank you, Tom. I appreciate it, and we appreciate your support of the event today and of Ed. Ed, a few questions for you. We got a little time left. So, as I mentioned, everyone, go ahead and type your questions in the Q&A box. Leave the default set to all panelists, and we will take a look at those. First question, Ed, did you need to provide incentives for people to change behavior, or was presenting them with the data enough?
Well, we used to joke. I sort of have a tagline that I've used with some of the IT folks over the years, do it or work somewhere else, but nobody will let me use that. So we didn't, but I'll tell you, we're really vocal, and we try to communicate well in the organization about what financial health looks like. In fact, we have gain sharing goals for the entire organization, so each employee is eligible for gain sharing, and one of the biggest goals every year is our operating margin. So what we did is talk about how these changes can contribute to the operating margin overall. And so that's the only incentive we did. I mean, we always had those same incentives in place. And that's part of why it was difficult, because we were trying to change culture. And, you know, people are always saying, well, what's in it for me? Well, we're keeping this organization open. We're working hard to do that. It's important for you and our community.
Yeah, that's a good point. Next question. Faster throughput usually means those who discharge are rewarded with a new admission, and I sense the sarcasm there. How do you mollify this effect for productive units? You know, we often know that towards the end of a shift, nurses aren't really looking to get a new admit. So how is that dynamic played into what you're trying to do?
Yeah, so my wife is an RN and has been for a number of years, and I remember her saying one time she came home and said something about, you know, one of the things that they say is keep them alive to 7:35, you know, because shift change was 7:30, and they didn't want to have to deal with that, you know, the paperwork and the admission. And,
right.
and I think you're right. I mean, people are worried about that, but honestly, it's just a shift in how you think about the work. You're going to get that work anyhow, unless you're able to kind of keep it until after shift change, but that stuff becomes really obvious when you see the data. And things present themselves. You know, the discharge order was written. Now we know what time that was entered into the system. We know what time the patient physically left the unit. So what was that delay for? Why is there a delta in there? And it was just holding people accountable for still doing their job and trying to explain and communicate, you know, how this isn't adding work. It's just changing when you may do some of the work, but we're still going to have the same number of patients. The volume is not going to be any different.
Yeah, so you could get to that level of data where you're having a frank conversation with a particular employee that says something like, we see that you're consistently never admitting someone after 5 o'clock, even though the discharge orders were written 2 hours earlier. You could see that.
That's right, and the best part is a lot of that feedback came from the process action team, which were the peers. They were the people doing those same jobs, you know, so I think it was more effective to communicate that way than just have a director or the CNO talk to somebody about it.
Yeah. Next question, who were the most important staff people in helping to make the changes?
You mean besides the CIO, right?
Of course. Well, that's you didn't help. You made them. Yeah. Who helped you?
You know, it was, I'll be honest, it was that group and that process action team, which is made up of folks from physicians down to people in environmental services that literally clean the rooms. I think that group, which has changed over time, you know, people come and go a little bit, but that's been the most effective component, the most sustainable piece, because now they understand, regardless of where your actual area that you normally work is, what the data looks like across the organization and what it means to you in your area. You know, if there's a backlog of 10 patients in the ED that are going to be admitted, you know, what that's going to mean to environmental services or to dietary or whatever the case might be. So the folks who actually do the job, getting them to the point where they were educated enough to understand that data and what it meant, I think that was the key for us.
Now, would you say you spearheaded this project? I mean, was this project like you drove it from the beginning?
I'd say a little, maybe more than in some organizations, just because of the way some of our department structure is here. It's worked out to that. Probably the true executive sponsor that we had is one of our other VPs who is over quality and risk management, but also has some of the ancillary departments to report to her, including the case management team. That she drove the steering committee from the executive level on down, which is super helpful, you know, super good. And maybe as much as anything, the entire senior team was pretty engaged in the process, including our CEO.
What's your advice to other CIOs who may want to engage in any project like this where you are really stepping outside of quote-unquote IT and you're getting involved with folks and with people outside of the department? Did you find you had to overcome some turf protection type stuff of, you know, hey, IT, stay over by IT, don't worry about what I'm doing over here? And how would you recommend CIOs who want to sort of take on some non-core IT projects, how can they go about engaging with these other folks so that people aren't protective of their turf?
You know, what's cool is, as a CIO, you at least end up understanding to some level all of the business things that we have in a hospital and the workflows, clinical and non-clinical. So you've got a really good background, I think, of the organization and the business that you're in. I think it's fun to step outside of that. I try to approach a lot of these projects as not IT projects because nobody cares. If you just got another IT project, you know, that's fine, do your IT thing. But we're running a hospital here. I think if you engage people to understand that this is an organizational project, for whatever it might be, that you'll get a lot more buy-in on those things. And don't be afraid to take risks, you know. To me, it's kind of fun working in IT and healthcare. There's just so many things going on. Change over the last 10 years has been incredible, and there's still probably a lot to do.
Just as a final question, how do you carve out time or make something like this a priority? It seems like there's so much to do that you could spend every day and work 12 hours a day just doing sort of the putting out the fires and doing the meaningful use stuff and security stuff. How do you carve out some bandwidth to do these kind of, I don't know, above and beyond projects? No one's going to get mad at you for not doing this. You know what I mean?
Right. Yeah, that's hard because there is a lot going on. I'll tell you an advantage that we have here, but I think a lot of people are in the same boat. There are a lot of people working in IT at this hospital a lot smarter than I am. So they're so good. If you effectively, you know, delegate the right things to people, they take a lot of pride in doing it. They can own it, go with it. I'm not good at details. I don't want to be a project manager necessarily or something like that, you know. And so I think I'm very fortunate that the folks who work here, we're not huge. We got like 26 people in IT total, but they do a lot of work and they're really good. That helps me, you know, be able to do some of the other things. I think some of it is the structure of the organization. We're big enough to be like a big guy, but we're small enough that we don't have a lot of embedded layers that maybe slow things down, so that makes it kind of fun. And you know, I have a great relationship with my CEO on the board, and I think that helps too. So all those things, creating the relationships, having smart people that work with you makes a big difference. And as you can show that things that you work on have made an impact and improvement, you'll get more.
Well, I think that's a very, very good answer. The concept of having a great staff and then being able to delegate properly and effectively really can free you up. So that's a good point for some of our folks who may seem a little overwhelmed. They might want to look at that aspect and see if they're holding on to a bit too many detail-oriented projects. With that, I want to thank you, Ed, so much. Look forward to having you back to talk about another topic. You're great at this. I want to thank Tom and MedHost for sponsoring. And as I mentioned, we have a recording. You'll receive a link to the archive when it's ready. Separate registration is required. For those of you that hold the CHIME CIO certification, make sure you report that to CHIME unless you've asked us to, and we'll do it, one CEU for each of our events. And questions, comments, email me, and you can go to our site to see our upcoming events and our last 12 months of archives. So with that, I want to again thank Ed, Tom, all our attendees, and everybody have a wonderful day.